In this talk, we're going to focus on the clavicle, which, as we saw in the introduction, is really a strut. So the clavicle is an S-shaped flat bone and is in fact the only horizontal long bone in the body. Traditionally, it's divided into lateral, middle and medial thirds. However, in practice, it's much better to divide the clavicle into fifths. So there's the lateral fifth, the medial fifth and the middle 3/5. The reason for this is that the AC joint and its coracoclavicular ligaments and the SC joint with its ligaments mean that fractures in this area are relatively uncommon and are different and are treated differently. So we're predominantly going to concentrate on middle third fractures. So the mechanism of injury, this tends to be a direct injury or either a fall generally from a height. The clinical presentation, the patients often have pain and swelling and point tenderness over the site of the fracture. The arm is generally held adducted and supported, and there tends to be varying levels of displacement. The more displacement there is, often particularly with shortening, the more issues they have with scapulothoracic dysfunction. So as we saw in the last talk with regards to protraction of the scapula, this can occur with the more displaced clavicle fractures. And it's important to assess skin tenting and integrity. Very rarely there can be issues with skin integrity, particularly if there's a very sharp point to the fracture. With regards to imaging, the vast majority of clavicle fractures can be managed just with x-rays, and it's important to appreciate the difference between an AP view and a 20 to 30 degree cephalad view. The cephalad view gives a much better appreciation of the sigmoid curve to the clavicle, and it gives a much truer representation of the displacement. So these are exactly the same fractures, and you can see the cephalad view shows that the fracture is more displaced and gives a better idea, particularly with regards to potential posterior displacement. CT scans are used rarely. This is a reformatted scan to look at the fracture fragment placements. It's rare that we require this. We tend to normally use a CT scan to look for evidence of delayed or non-union. It's sometimes very difficult in fractures that are a little bit older on a plain x-ray to see whether they've truly united. So a CT scan can be very useful there. So fracture classification is important. This really helps us to know how we're going to treat fractures. So the important thing is to look at the position of the fracture, so whether it's in the middle or lateral or medial parts of the bone. Comminuted is important, so you can have a spiral fracture, an oblique fracture, a transverse fracture and a comminuted fracture. And actually these fractures occur with increasing amounts of energy. So a comminuted fracture, not only is the bone broken into smaller parts, it's required more energy to do this. This often can have an effect on the surrounding soft tissues, the likelihood of this to heal and perhaps the requirement for surgery. So for midshaft clavicle fractures, there are a number of classification systems. This is the Robinson classification system. And the important thing is as the number gets higher, the comminution gets higher. And really something that is a telltale sign of a fracture that's going to go on to non-union is if you have a vertical segmental comminuted fragment. So in this fracture, that vertical fragment means there's a high chance that if you don't fix this, this fracture just will not unite. So ultimately you're going to have to do something down the line if you don't fix it straight away. Lateral clavicle fractures, the importance for lateral clavicle fractures are really the type 2A and B and the type 5. These fractures have occurred just medial to the coracoclavicular ligaments, or they've involved just the conoid ligament. So they're akin in a way to an AC joint dislocation, so that the medial part of the clavicle will have an unopposed pull of trapezius, so that always tends to get displaced. So type 2 and type 5 lateral clavicle fractures tend to have issues and go on to a non-union and require surgery. Displacement, as a general rule, on plain x-rays we really look at shortening, and shortening greater than 20 millimeters may lead to functional deficit. There's not a lot of agreement as to exactly how we measure that shortening, so a number of different methods have been described. Some people like to look at both sides and to compare both sides. However, it's very difficult to truly make sure you've got an AP of both clavicles, so a more surefire way is to actually use a CT scan. However, shortening isn't the only component, and this is something that is not generally appreciated on a plain x-ray, and it's to do with functional deficit. And I've just got a little example here. So if we look at this clavicle here, if we have a fracture in this spot, you can have an element of shortening, but actually there's no imaging that really shows you how displaced or protracted the fracture is. So this is exactly the same fracture configuration, but actually just the way it lies, it can cause greater issues with scapulothoracic function. And a lot of my decisions with regards to fixing clavicle fractures aren't just on the x-ray. It's very important to examine the patient to see exactly what's happening with their scapula. This is a very useful prognostic indicator that was written up again by Mike Robinson, and it's a system by which you can put in a number of factors to see the likelihood of a fracture going on to a non-union. So factors that will increase the chance of a non-union are the amount of comminution, whether the patient smokes, or whether the age of the patient, and actually females are more likely to have non-unions than males. So for minimally displaced fractures, non-operative treatment really involves sling for comfort, and I really recommend that for 2 weeks or as they begin to mobilise with comfort, so they can start to mobilise at about 3 to 4 weeks. Patients come from the continent where they like to use this type of figure-of-8 brace. Really, there's no evidence for that. I don't think it really makes a big difference. In fact, it is generally quite uncomfortable, and I don't think it actually reduces the clavicle or aids recovery. So most patients we'll see back at 4 weeks just to make sure that the fracture position hasn't displaced. Most patients after about a month are fine for day-to-day activities, and it probably takes about 3 months before they can return to contact sports. So the indications for clavicle fixation, the absolute indications are an open fracture or neurovascular injury, which I mentioned are relatively unusual. So all other indications are relative. So those are to do with functional recovery. So that's to do with having a functional deficit. So that's the position of the fracture, or whether they've got issues with scapulothoracic function, or when you look at the prognostic indicator, there's a very high chance that they're going to go on to a non-union. Another indication, particularly with regards to sports, is speed of recovery. If you fix someone's clavicle up, literally within a week or two, they will be able to return, not necessarily to contact sports, to most other sports. I work near Newmarket, and the jockeys will come in and I'll fix them up, and they will be back riding within a week or two. And a third and less common reason is cosmesis. So for this is an example of a patient who's got a comminuted fracture, so they've got this vertical fragment. So they had issues actually with regards to their scapulothoracic function. And also, if you put them into the prognostic indicator, there's a very high chance this will go on to a non-union. So this is after they've been fixed up, and really almost straight away they're feeling a lot better. And actually a lot of the patients are a bit like the chap we saw in the second talk who had a posterior dislocation of his sternoclavicular joint. Often a lot of these patients are complaining of scapular problems and pain as well as their clavicle. This is an example of a patient who's got shortening with scapular protraction. So there's 24 millimeters on this x-ray, and this is it reduced. And this is an example of moderate displacement. So this actually was a jockey. So we fixed this up, and they were back riding within a couple of weeks. The management of lateral end or lateral fifth clavicle fractures tends to be slightly different. The vast majority of fractures that are within or lateral to the coracoclavicular ligament tend to be minimally displaced and can generally be treated non-operatively. However, as we mentioned earlier when we were looking at the classification, the type 2 and the type 5 fractures, where the fracture site is just medial to the coracoclavicular ligaments or through the coracoclavicular ligaments, means that the medial part of the clavicle is likely to be significantly displaced by trapezius. In this instance, we would normally consider fixing these fractures. So we have to use a special plate that is widened at the lateral end so we can get sufficient smaller screws in. And as you can see where the arrow points, there's also a little anchor that's gone into the coracoid that's helped to reconstruct the forces of the coracoclavicular ligaments. The management of clavicle fractures in pediatric patients is very different indeed. The ability to heal and the fact that children are growing mean that we can accept almost any level of displacement, and in fact it's incredibly rare that surgery would ever be considered for any pediatric fracture. So this is a 13-year-old boy who has got this fracture. This is him back at the clinic at 5 weeks. Clinically, he says he's pain-free, he's got a full return to function, but he's obviously got a bit of a lump present. This is him at 3 months, and you can see that the callus has really formed and solidified, and at 10 months you can already see that an element of growth has occurred, so the fracture is disappearing, so he will have no issues with regards to functional deficit.